I know some of you in the workshop here from previous roles in my life. I'm currently the All Ireland Endorsement Body for Community Work Education and Training Coordinator. It's a bit of a mouthful, AIEB. So I had just introduced myself, Ciara Shanahan, so I'm the chairperson. So like I said before, if you do have comments or questions, enter them into the chat. We'll try and incorporate them as appropriate. But maybe I'd call on now Anne Friel and Brigid Quirke. Maybe if we start with Anne, hopefully your reception will hold up. Maybe Anne, you just introduce yourself as one of the two key speakers for the workshop, if you don't mind, and you need to take yourself off mute.
Hi everyone, my name is Anne Friel. I am a member of the travel community and was asked to come and have a conversation with Brigid Quirke in relation to health inequalities as part of this workshop. I do work in the local traveller community development human rights organisation here in Donegal in relation to health inequalities, and I coordinate the primary healthcare project, which is made up of members of the travel community working on social determinants underpinned by community development to improve health outcomes in the travel community locally and nationally. And that's, thanks very much, Ciara.
Thanks, Anne. Maybe we'll hand over to you, Brigid, to introduce yourself, if that's okay. You just need to take yourself off mute.
Okay, I got a bit of a fright there when we disappeared out of the groups. I thought, oh, I've lost the group. So anyway, thank you very much for inviting me. My name is Brigid Quirke. I suppose my background, I trained as a nurse midwife. I worked overseas with Concern for 10 years in relief and development, where I think I learned to understand a lot about health inequalities and community engagement and responses. I then worked in a rural development project in Connemara, and then I worked with Family Point for over 20 years, National Traveller Organisation. I was then the field coordinator for the All Ireland Traveller Health Study based in UCD, and I continued to work there for 6 years as in the area of research. In May this year, I took up the position as a project manager for Traveller Health with the National Social Inclusion Office with the HSC. And that's where I am currently. Thank you.
Thanks, Brigid. I'm just thinking, given the size of the group, I thought the workshops would be bigger, so I wasn't going to ask people to introduce themselves, but given the size of the group, if people wouldn't mind if I call on them just to unmute themselves and introduce themselves, and maybe just say the organisation you're working with or your particular area of work that you're interested in, just to give it a bit of context, if that's okay. So I'm just going to ask people to introduce themselves based on where you come up on my screen. So Noreen Coughlin.
Hi everyone, I'm Noreen Coughlin. I'm based here in Drogheda. I'm the Community Development Officer with Loud Leader Partnership. And I'm particularly interested in this topic. And in a previous life in Ballymun, I would have been part of setting up a community health forum and looking at something similar here. And we've had some kind of blockages, and be very interested, Brigid, in some of your links on how to, like, people often describe some of our target groups hard to reach. My hard to reach group is the HSE. And so I'd be very interested in how to unblock that, because it just doesn't make sense to have a community health forum without the relevant everybody at the table. And I think our biggest challenge is the concept of community development as an approach to tackle inequalities, just even that as a concept, and understanding, I suppose, really meaningful, that communities have meaningful solutions to these complex issues. Thanks. Sorry, I overtalked.
No, that's great, Noreen. Thanks very much for that. Mary Claire.
Hi, I'm Mary Claire Wallace. I work for South Dublin County Partnership, based in Glenshane in Tala. We've run a health fair every year until last year or the year before. So very interested in Michael and listening to the discussion. Yeah, so thank you.
That's great. Thanks, Mary Claire. Barry Mooney.
Hey everyone, my name is Barry. I'm from Donegal Travellers Project up in Donegal, but I'm the education development worker. But I suppose I'm in this workshop to get more kind of insight on health, basically, and try and give me a good briefing on health in general, specifically traveller and other ethnic minorities.
Thank you, Barry. Aoife O'Neill.
Hello everyone, my name is Aoife O'Neill. I'm a project manager Traveller Health in the HSC, and I work alongside Brigid here, so delighted to be here. Thank you.
Okay, that's great. So Noreen has two HSE contacts here on the screen in front of her. Vivian.
Hi, I'm Vivian Ivers. I'm a primary healthcare coordinator with Galway Traveller Movement covering South East Galway.
Thanks, Vivian. Kathleen.
Hi, I'm Kathleen Sweeney. I work with the coordinate the primary healthcare program for Galway City, Sarina. Yeah.
That's great. Thanks, Kathleen. And Felicia?
Hi there, I am the Family Support and Community Development Worker with the South Roscommon Family Resource Centre in Roscommon Town.
Great, thanks, Felicia. And I have somebody on the phone, C. Hogan.
Hi there, my name is Karen Hogan. I'm a coordinator with Pobble. I work on the Launch Care Programme and the Healthy Ireland Fund as well. So really enjoyed the conversation this morning and looking forward to the discussion here, particularly to inform my work. And apologies, my reception's really bad, so I put on my camera. I won't be here.
That's okay. I think that might hit a few people during the workshop anyway. Thanks, Karen. And Edel.
Hi everyone, I'm a colleague of Karen's, so I work in the Healthy Ireland Fund with Pobble as well. My background would be in youth and community work, so I've only recently moved into Pobble as the organisation. So I was managing a youth project up until about 6 months ago. So yeah, really interested to see what this discussion is about.
Okay, that's great. Thanks, Edel. And I introduced Jacinta already, who's here for the purpose of note taking. And Ronnie, we all, I suppose, got to know you a bit more in the previous session if we didn't know you already. So I think we'll kick off if that's okay with everyone. So Brigid and Anne, if you'd make sure that I suppose you're unmuted for the moment because you're going to be called to answer questions. So I suppose we're looking at addressing health inequalities, but in order to look at how to address them, we do need to look back a little bit. So what has been the impact of the pandemic on health and health inequalities from your perspectives? And maybe Brigid, do you want to kick off?
Okay, thank you. I suppose we have heard a lot of it emerge in the discussion this morning. A lot of the issues have come up. Obviously, a big thing is, I think, and the Marmot report that Ronnie referred to, which I think we could put up a link to circulate if people want to look at it. It would be quite interesting. Is the starting point, and I think the issue in Ireland, I suppose we're looking specifically, was because of the I suppose the cutback in funding, community and voluntary sector, the cutback, I suppose, across the issues that would be considered the social determinants of health had been impacted due to the recession. I think we started probably at a point where the inequalities in Ireland had probably expanded. There was more polarization in terms of wealth. So in terms of the impact then was disproportionate, I think, on those communities. And I think as was highlighted this morning, there's an issue for the people who are most affected were the people who have insecure employment, were unemployed, could have been put on furlough, people who are higher at risk of getting conditions were the people who were working more directly in low income jobs, maybe like taxi drivers, bus drivers, people who were security, those low paid insecure positions, being higher risk. Obviously ethnic minority groups, it shows from all the evidence at a much higher level. And I think it's something that Marmot talked about, that there's nearly 10% difference in mortality when you look at the most deprived to the least deprived communities in terms of life expectancy. And the highest rate of increase in that period was the people who live in the most affluent areas had an increase of 10%, whereas the others had a decrease of 10%. So it's actually quite powerful, that idea, talking about the social determinants and poverty. It's the people who already experience inequalities, further experience of that, they were further exacerbated. And I suppose also the issue is poorer people generally have more chronic conditions. I think as again that Mike pointed out, they're often not recognized in time, they're not treated in time, therefore they suffer disproportionately, often die from diseases that actually have never been diagnosed or treated. So that early recognition intervention in people who experience inequalities in terms of accessing appropriate care at the appropriate time is creating that disproportionate outcome. So I suppose there was a disproportionate, and I think it exacerbated existing health inequalities. Obviously, the pandemic continues to have an impact in that there's long COVID, which again we understand will be experienced more by people who are living with inequalities. Also, the issue is it's now beginning to show up that people, because of the shutdown in the delivery of normal services, that some people haven't been diagnosed maybe early enough, intervention around cancer, some people with heart disease, GPs, people weren't going out doing visits. So I suppose the fact we haven't got the resumption of normal services, but also then the impact that slowdown in service delivery will continue. And I think we mightn't see it immediately, but I think, as Ronnie said, some of that will be longer term impact on these. So I think, yeah, we need to look at it now. We need to be aware of it to begin to change that. But anyway,
yeah, I think that kind of leads that what I'm picking up there from what you said is you're talking about the disproportionate effect on more vulnerable communities, more marginalised communities, because it exacerbated the inequalities that already existed. They've just been compounded, which I suppose, Anne, would bring me over to yourself, because as you've introduced yourself, you work in a traveller project. So from your perspective, how would you respond to that question, the impact of the pandemic on health and health inequalities?
Well, I'm hoping to talk about the impacts of the pandemic on the travel community, because as a community working with the travel community throughout the pandemic and seeing the real life experiences and the real challenges on the ground that was and through the whole pandemic. But it's really important to acknowledge as well, travellers experienced poor health inequalities long before the pandemic. And local travel organisations like ourselves, with national organisations, has been working towards a better health outcome for the travel community. COVID-19 has brought many challenges, but it's also exacerbated, as Brigid said, around health inequalities in terms of access and services, in terms of accommodation and education, and seeing the rise in experience of racism and discrimination. We did have some positive elements of being maybe recognised as a priority group through COVID-19 because of poor health inequalities, because old age disease does present much younger in the travel community at a younger age, and that was by NPHET and public health. And it's really the outbreak, we always see the outbreak describes of treating everybody the same, but unfortunately in this pandemic, the challenges and barriers for the travel community was different. We have seen, in relation to accommodation, we are aware that there was 3,000 travel men, women and children still living on the roadside, still living in poor conditions in halting sites, some without even the basic of access to water as a human right. We heard messages from the World Health Organization said to reduce the spread of the virus, wash your hands with hot soapy water. That might seem so simple to a lot of people, but that was not accessible for many members of the travel community throughout Ireland. We've seen that travel organisation had to go out when messages around the pandemic, we had a culture that weren't culture appropriate for members of the travel community, for the Roma community, for other ethnic minority groups. The public messages were really steered towards the white settled population. So like local organisations, community organisations had adapted a lot of culture appropriate materials to get the message out to the travel community. We've seen a massive gap in terms of education. We are aware that Roma and traveller children have the lowest entertainment in education, and we've seen where the online schooling at home brought many challenges for traveller children and Roma children because of poverty, there's a divide, living on the side of the road, no electricity, haven't got the technology. And at a local level, we've supported a number of families to get the technology for schooling online. But the reality of it, there was no electricity to charge these devices. So that brought challenges. And there's a fear that travel children will be more further apart. We've also seen a rise in race and discrimination around social media in terms of, way travellers are seen within society as being dirty and carrying diseases. And we were blamed in a number of different settings of spreading the virus. And especially through Facebook and social media that occurred. So the virus always seems to be treating everybody the same, but we know as a travel community, the virus didn't, because we were never in power. Before the pandemic happened, we were living with poor health inequalities, so we couldn't be at the same level. And I've been at many agency meetings through this pandemic where agencies would say to me, oh, we're all in this together. But in actual fact, we weren't. If people had to cocoon or isolate living on the side of the road, they hadn't the space to do that. And Dr. Mike Ryan talked about the social element. The social element, having the family connection on our daily lives in the travel community is quite important. And if you live in a halting site or you live in a group housing, to close your door out and not mix with other family members was challenging. people over the age of 65 had to isolate within the travel community for the poor health inequalities, and that brought challenges. And we've seen a lot of that on the ground working. And then mental health. We know that from the All-Ireland Travel Health Study that members of the travel community die by suicide 7 times higher. But that brought the social element now with the mix of families and a major lockdown has brought challenges around mental health also to the travel community.
Thanks, Anne. That's a really comprehensive answer. In some ways, you've gone on, because the next question I was going to put to you was what effects did the national response have on communities? So you've already kind of raised some of that within what you've said, Anne, but maybe Brigid, you'd like to come in on that, would you?
Yeah, I think, yes, and in terms, I think particularly applying it to one population in terms of the experience of travellers, because as you say, it is all vulnerable groups experience it. I do think the issue might have been in terms of some of the national responses. I think it, as Anne has said, was the lockdown, as was said maybe by Mike earlier, and Ronnie, that you assume people at homes when you were told to stay at home, you assumed you had space for families to live together. It didn't take into account maybe you didn't have access to space or green space within your 5K if you lived in congregated settings. Obviously you're higher risk. It assumed maybe you had access to social media. It didn't take into account digital poverty, and that we all had Netflix, you know. So there was certain assumptions made. It was easier for some people to isolate. Obviously, as Anne has said, if you lived in a trailer with 10 people and you're asked to wash your hands, you've no access to water. It was totally unrealistic. So I think that maybe again the containment measures had a disproportionate impact on the most vulnerable groups, who were more likely to live in poor accommodation conditions to start with, in terms of Roma travellers. A direct provision was a big issue in terms of congregated settings. I come from Carcevine, and there was a particularly bad experience during COVID when they transferred people from 7 centres and they all ended up in the one, and there was 26 cases, and they were sharing rooms, they were sharing facilities because there was no space to actually allow them single rooms. So I suppose in terms of national response, it was required and maybe did have an impact, but again, there wasn't that issue that people looked at across the board, how that would disproportionately impact on people. Now, in terms of the positives, which again Anne had referred to, I suppose one of the positive things to come out of it was the work particularly the traveller groups did in responding and beginning to engage with the public health, and public health were very open in terms of the HSE engagement through public health, the Department of Housing coming together, looking at putting additional facilities and resources into sites that had no services, putting in water, sanitation, providing extra mobile homes. In terms of Roma, they created this Roma hotel. So about acknowledging that maybe within those communities you can't isolate to reduce the risk of spreading. So they began to develop maybe, I suppose you'd say, more culturally appropriate responses. And I think actually there was a very good learning and a very good, I think, relationship established between the NGOs, public health, and the Department of Housing. And I think it was a learning curve for everyone. I think public health for the first time actually had the opportunity to go out and they visited sites and were aware, hadn't realized how bad the living conditions were for some of the communities. So I think that was important, and it was a learning, and I think public health did come to the fore. And I think it'd be really good if into the future the public health would take on a stronger role in terms of looking at those issues. Obviously, the other issue maybe wasn't looked at is again the determinants in terms of poverty, and maybe looking at the need for more affirmative action, that it's not the same provision will suit everyone. Some people, that proportionate universalism based on the need of each of the groups needs to be taken into account. So I think the idea is, again, Mike had mentioned that you have someone who's in a lower income had to decide, I have to stay at home to look after my children, they're off school, I don't have a choice. People maybe like travellers or Roma who don't have a great standard of education, an expectation they can support their children to continue their education at home, assuming again they had access to digital equipment to be able to do that. So I think there was positives and negatives, and I think hopefully out of some of the positives, if we could hang on to some of those to bring them forward to the next stage, which I think is your next question.
Well, it is, and yeah, I was curious. So as somebody, for those of you who don't know, I worked in a traveller project until about 5 months ago. I'm really curious, some of the positives that you've mentioned, have they continued, or are they under threat of, I suppose, of disappearing as mechanisms and structures and engagement?
Maybe that my colleagues who work with travellers could tell you that directly, but I know just for myself in the national office, I know that we had understood that a lot of the circulars that were put in place, again through lobbying from the organisations, to ensure there was no evictions, that there was a budget put in place to provide extra facilities where they were needed. There was an assessment form and process created to assess the sites, the roadsides where that was needed, and that was developed by the office I'm working in, and with the traveller groups. But I know of late that people are saying, I got one case, someone rang up and said in Clare that they got all these extra facilities when a family had COVID, they were on the roadside. But once they recovered from COVID, they came in and took the services away. Now, that shouldn't happen, because we understood that even though there was a deadline when we did contact Department of Housing, they're saying no, that those supports are continuing. But I'm not too sure how far in advance, and if we have anything in writing to know how long they continue. But again, maybe Anne or Ronnie may be in a better position to answer the impact on travellers on the ground.
But that was a directive came out from the Department of Housing through the pandemic. But the reality on the ground, what them services was a portable toilet. And anybody ever used a portable toilet, festivals or anything, there was no running water. It was a flush toilet. Some families benefit maybe getting a generator, but I don't think that all traveller families across Ireland benefit from them services. In some areas, the local authority was slower of getting them services out than other areas. But I know some areas that they pulled back on them services if they weren't isolating or they just took away the portable toilets. But for the minimum standard, what was provided in a global pandemic was very minimal by local authorities. But the lockdown also, created a lot of isolation and loneliness and no sense of connection to the traveller community. And if you look with the Roma community, if people were working maybe in car washes, they weren't entitled to any income. And we have a Roma project here who had many challenges supporting families. And the movement of the scheme on social welfare went fortnightly, and that created a lot of issues for people living in poverty, because children were at home and they were eating more, there was more fuel being used, and they were eating more. So families can really dependable on the food banks, because they couldn't really work out every second week, of getting payments, and that was challenging for families as well. But definitely the national response from the Department of Housing, I don't think, unless Ronnie wants to come in there, in some areas, some of them services were taken away, but there were minimal services, and depends what part of the country you lived in as well.
It also depended on the engagement of public health. So if you had a good public health doctor, they could make demands on the local authority, which were usually met. But as Anne says, a lot of them were short term, they were immediate emergency responses, and they aren't sustainable. So the problem is it's back to the future, that it's assumed the local authorities will make provision, which many of us who are involved directly know in terms of our experience of local authorities with traveller accommodation. They're certainly, their track record leaves a lot to be desired. But I do think the public health involvement is something that has to become a legacy of COVID, and that there has to be that they become part of the traveller health units or whatever, so that it becomes institutionalized, so that because there was very good progress, and even just as Brigid said, the public health doctors, some of them were so shocked at what they saw on the traveller sites, like they really were. You'd think, well, where have you been for the last whatever? But it was very helpful,
So that's possibly when we're coming to look at one clear call for action. There's food for thought there in that, just in terms of the involvement of services beyond ourselves, who can, I suppose, bring that power to the table, but make local authorities more accountable. And I know certainly from working in Galway, there was a public health doctor there who played a crucial role in, supporting us to to secure some limited facilities for families. But I know as of my last involvement, she was very keen to continue to stay involved in that work, and I suppose pushing the health agenda for travellers forward, and making the links between their accommodation situation, between education and the impact on traveller health.
One of the challenges, though, here, if I might add, was the lack of parity of esteem between the role of the public health doctors and the primary healthcare projects was quite problematic, to be quite honest. I'm not saying they were all bad, but I'm also saying they weren't all good, that some thought they were the experts, even though they'd only kind of discovered travellers during the pandemic. So they need to have more respect for community workers and primary healthcare coordinators and workers than some of them demonstrated, so just having their involvement could mean that actually the traveller health infrastructure become marginalised and become further removed. So we have to be very clear, that it isn't their involvement on any terms, but it's kind of not only on our terms, but that we negotiate what the terms of engagement are, so that there is due mutual respect for the different roles, because otherwise I can see that becoming problematic. The other thing, did people pick up on the minister this morning? He said is it that the public health consultants have been appointed as consultants now? I was wondering, one of the things we were looking for was a national lead on traveller and Roma health. A national public health lead is a national public health specialist who would be 0.5 travellers and 0.5 Roma. Is that what he was talking about, or is that the general ones? Does anybody know? No.
I understood it was the general ones, but
okay,
but I'm not 100%
sure.
sure.
Maybe if that was
included.
Yeah,
no, that's my understanding as well. They had been fighting for that role of parity with consultants, and I think that is, because I think the number was 78 or something. Quite a high
84,
number.
84, yeah, is what he said.
So it is all of them. Yeah. I think maybe that.
Sorry, Ronnie, just going to come back to what you were saying about public health and doctors. I have to say, it depends what area you came from. Even with their own experience, community workers and working in the area of health was on the ground. I think there was elements where public health kind of blamed the travel community and problematized them in relation to the pandemic, and we've seen that on the ground. And even in relation to contract tracers, if they did have the time, or they did ask the question around the ethic identifier question around the pandemic, where their bias and their prejudice towards the travel community was seen, where they left members of the travel community afraid to identify as travellers, where they did ask the questions because they were looking for information in relation to other family members. We're talking about other family members, and that was quite a negative experience in the travel community, especially in relation to a pandemic. And that came up in our own area where I'm working in Donegal.
Yeah, that's a good point, and I know that people in other areas of the country would have had, encountered similar issues in that regard, which I suppose is moving us on towards another question that I want to put to yourself and Brigid, is what lessons do we need to learn, or what changes do we need to make to ensure a just recovery based on equality in terms of health?
I know that Ronnie and Dr. McRyan talked this morning, but I think there's definitely a need for an ethic identifier. We need data collection, we need a universal question, and we need a human rights framework. And people need to be trained on ethic identifier, on how to ask the question. Because many of the services I've spoken to in the past said, well, we don't feel comfortable asking that question. If you don't feel comfortable asking that question, the person answering will also feel uncomfortable. But we definitely need an ethic identifier, and we need real time, as Dr. Ryan says this morning. We need attitudes to change around race and discrimination. We need equality proofing, looking at how service should engage marginalised communities, and not blaming the community around contract tracing.
Not problematizing the community, as you put it as well earlier on. Okay, so you're really strongly talking about the ethnic identifiers. That's back to stratified data, not just based on gender, but having an ethnic identifier within it, or within a human rights framework, and real-time data, attitudes to change. challenging racism and discrimination and equality proofing mechanisms. Brigid, have you anything you'd like to come in with there?
Yeah, no, I totally support. I think data, as they say, you know, if as Ryan said, if you're not counted, you don't count. So it's really important. We need that data. We could then have seen maybe disproportionate impact on those vulnerable groups, and then to ensure we have the proportionate response to ensure equality of outcomes in relation to those. I would also think, though, the issue that came up around addressing the whole social determinants, it's like all we're doing is tinkering around with a system that is inequitable to start with. And I'm saying this is not blaming the services. I think, as Mike Ryan pointed out, we people who are very committed, they're dealing with a tsunami of need, and they're trying to respond, and there isn't time to nearly be proactive because people are so busy being reactive. So I think we do need to look at the social determinants of health as a model. I am concerned that in the new policies there isn't enough focus. When they talk about social determinants, they talk about those 17 local projects. So they're talking about how you address inequalities. They're not actually looking at upstream, as they talk about the causes of causes. Because until we start dealing with the causes of causes, we'll be dealing with the consequences, which are health inequalities. So I know what Mike Ryan talked about this morning, and I know often quote, one of my favorites is Derek Wanless, who was a banker in the UK, and he made a statement, this is not so much what he said, but who he was, that if you invested something like 10 million upstream, don't quote my figures now, but it's the principle, you would save 30 million downstream. So his point was the people who use the services most, put most pressure on the system, are the poorest people because they suffer more health inequalities. So what you need to do is get rid of health inequalities. So you have to go back and invest upstream in addressing educational inequalities, employment inequalities, poverty, and that's how you would reduce the burden on the system. So I think we do need within Ireland to relook at what's in, of course, the social determinants. And I think Ronnie did talk about it at one of Marmot's recommendation around looking at ethnic inequalities, but he's also saying you could even do one that's about social determinants. You could just have a strategy addressing the social determinants of health, which would also address health inequalities. And I think that's essential because I think even asking for affirmative action or asking for the Department of Housing to do something here and there, you know, they are still suffering disproportionately. These are only small little inputs that are not going to create major changes. And I think the other thing Wanless said, and I'd like to quote a bit, there's an urgent need to do things differently. And he talks about don't bring back better. He's talking about bring back fairer, because he said we had inequalities, we have to address them. We need to build a society based on the principles of social justice, reduce inequalities of income and wealth, build a well-being income that puts achievement and health and well-being rather than narrow economic goals at the heart of government strategy. And he's saying actually New Zealand have taken on to do that. They have a new strategy, a government strategy that's putting the principles of addressing health inequalities and looking at social justice. So I think there may be models, but I think it's about, if we are saying, you know, it isn't about bringing back normal, new normal, we want to bring back better, we want to bring back fair, and how do we go about doing that would be my key message.
Yeah, and I suppose that leads me on to a question that I was thinking about. So what are the challenges for us as community workers? Because we're all here as community workers in one guise or another, you know, and if this is what we're looking for government to do, I suppose, how do we as community workers try and secure that, try and achieve that?
Yeah. Well, I think it's that, is it about, you know, engaging communities, about participation first, about ensuring the community are part of designing that bring back fair. I struggle. I know it is difficult. It is about talking to our local politicians. It's about advocacy. And maybe it's looking at some of those models of good practice in other countries. Like, you did wonder if you make a one less argument, which is an economic argument for those people who say we're coming back and after COVID, we've less resources. So we say, if you invest in reducing inequalities, you will actually save money. Now, the problem with that, again, as was spoken about this morning, we deal with a 4 to an 8 year cycle. You need a much longer term vision to say, if you want to spend the next 20 years in order to develop a system to address inequalities, you don't want political parties to keep changing and then they keep changing the way ahead. There needs to be a cross-government agreement. And again, you'll only deal with health, as Ronnie said, the current problem is the focus of the Department of Health is on health services. So we do need a cross, almost departmental commitment to health and health inequalities, the only way to address it. And I think we all have to play a part in that in terms of advocating, maybe producing the evidence, making submissions to show there's a better way to do it. I don't actually have an exact solution, but and the concerns. Interesting, I think that we've two people here from the Healthy Communities model in terms of rolling out, because again, that would be seen as a very positive initiative. But I know as part of my role in my office, looking at the National Traveller Roma Inclusion Strategy, a lot of the feedback we've got on the ground is that people feel that travellers are, and other groups, well, particularly travellers, are not getting access to that funding stream because in terms it works through obviously SICAP and LCBCs, and often they're not engaging with traveller and traveller groups, even though it's designed to address inequalities. It's often, again, exacerbating them because it's designed to address them, but they're not being included. And at the moment, that's anecdotal evidence. We're trying to gather evidence where we feel maybe those groups should be prioritised, and maybe the funding should be looked at going through direct through NGOs, through traveller groups or other NGOs on the ground, rather than having to go through LCDCs or SICAP. SICAP have an ethnic identifier, and I think there's as little as 9% of the funding has gone direct, say, to traveller groups. So there is an issue. So even things that are put in place, I think to the point that Anne made, we nearly need to quality proof some of the service responses as well and interventions, just to ensure, because again, it's where institutional discrimination comes in. Services are designed for the majority population and without intent to discriminate on people who live on the margins. You don't take it, you're assuming income, education, so capacity, and often then without intent. So I think there is a need for data, and maybe with that a proofing mechanism, along with maybe training on collection of and use of data, maybe proper guidelines, and maybe anti-racism codes of practice, I think, as well, ensuring that, because people have a fear if they identify themselves, as Anne has said there, you don't want to open yourself up to experiencing further discrimination. So you need to be assured if you identify yourself that that's respected.
Yeah, we actually I just link into what you were talking about, the social determinants of health. We have a comment in the chat. Mary Claire, do you want to turn on your mic maybe and just engage with that directly, given that we're a relatively small group? I think she's trying to turn off her mic.
Yeah, no, I'm going to the wrong place. Yeah, no, we did a survey up in Glenshane and Tallaght, and it was around adequate housing, and it identified all of these the issues around not upgrading windows, doors, all the heat loss that goes through that, the health issues related to that, both mental health as well as physical health, because people are struggling to try and live on a small income. And so you have to make choices about whether you're going to eat or whether you're going to pay heating bills. And, you know, like I say, at the moment, the heating, all the energy bills are going up and up. And this is going to be a very impactful problem this year, I think, even more than previous years, which it was already a problem. So, and it's wider, you know, as I say, it's certain areas, and it's attitudes, it's all of the stuff that's been talked about. It's attitudes to people. People get blamed for the situations that they're in, as opposed to actually, you know, so there's a real problem with attitudes as well. So you know, it's yeah, I mean, I had written all of those things down already: blame, language, attitudes, you know.
Yeah.
You know.
Yeah. Yeah, and obviously some of a lot of the discussion here has focused on the traveller community, but that is also wider than traveller community. That's why you know, you can see it in any discussions about homelessness, for example, the way homeless families are stigmatized, you know, blamed for being in their own situation rather than looking at the kind of structural issues with housing. So those, likewise, people with disabilities, etc., etc., etc. Women, we know,
seekers, migrants, the whole,
the
people,
whole,
anyone in congregated settings,
the whole.
One of the things I think in terms of a challenge, you know, for community workers is to make sure we continue the whole of government approach to social determinants. And that it probably needs to be led by the Department of Taoiseach, who led out a lot of the NEFIT stuff and the because they showed, you know, their leadership showed, you know, you could pool resources, you could pool expertise, you could make things happen that previously all of us had been told were impossible when there was political will. So I think we need to remove health from the Department of Health, because I think it's compartmentalized there, and that they take an approach of healthcare services, even though the Healthy Ireland framework talks the talk of health inequalities, talks about community development and inclusion. That hasn't been what's actually been seen on the ground, you know. And even HSE people would say that to you if they got another green bouncy ball or a green chair or a green flag, you know, that the marketing of it is beyond what it actually does in reality, you know, so that they need to resource, you know, if they're serious, it was to be a whole of government approach, but really that needs to happen by the Department of the Taoiseach probably, and not the Department of Health, you know.
Yeah, and actually that's where opportunities today, because the whole of government approach requires us all also not to work in silos, you know, and being single issue specific, but that we kind of use these opportunities to share learning and expertise and build alliances. That's why I mentioned that there's 2 HSE people, and somebody was saying about trying to build relationships with people at the HSE. We have to use these opportunities to, I suppose, develop working relationships with people, communicate with each other, and I suppose find common ground within it, because a lot of what we're talking about in terms of social determinants, that will have benefit to all communities, all the communities in which we work, if we're looking at health and how it relates to all the social determinants.
I think it's really important that we have a whole government approach in relation to health inequalities. So regardless what community you come from, health inequalities affect different communities different ways, but it must be underpinned by the social determinants. And I think that's the model we need to be looking for. And as Ronnie says, take it away from one department.
Okay, thanks, Anne. Ronnie, did you want to come back in there with that comment from the chat? You're on mute.
I'm on mute. Sorry, I'd be interested to hear what Karen or Adele have to say as the people who are involved in the Healthy Communities program, as I understood it, just in terms of what kind of recommendations they'd make.
Yeah, I suppose I'm 6 months in now, and I very much came into it with the community hat on. I think it's very broad at the minute. There's a lot of really, really great positive work going on across the country under the Healthy Ireland Fund. But it isn't standardized across the country. It isn't, you know, it's not really bound by statistics and data. It's more kind of anecdotal evidence, I think, that it informs it at a local level. I know that going forward, that's something that that they're trying to improve on, to try and make it more targeted, more specific, and really to get really positive outcomes for different communities across the country. So yeah, that's from my observation, as I say, I'm only 6 months in, so I don't know all the workings from the past. You know, it's a big framework. I don't know every working detail of it, but yeah, it's developing, and there's really great work going on the ground, and that's, for me, it was such an insight and such a positive piece of work.
Okay.
Thanks, Adele. Thanks. I think that some of what you brought up links back to what we were talking about. So, I mean, because there's significant investment in the Healthy Ireland funds, that the more that's based on responding to the data that's available, the more targeted the work can be, the more, I suppose, the greater the output for the investment can be, you know, which is, I suppose, often what, I suppose, certainly as community workers, we hear that, you know, what we're looking for requires a lot of investment and a longer term process, and that's where having data that will help us target that funding more appropriately will have, I suppose, achieve more success for the kind of models of work that we look at. Is there anybody who hasn't come in yet at this stage who'd like to make a comment or an observation or ask a question? Are are you all happy to progress at what we've heard? Because I'm just conscious we don't have a huge amount of time left, so we do have to try and agree one clear call to action for community workers in terms of addressing health inequalities. So I mean, I suppose some of the common themes that I've heard emerging is we want to well, obviously Ronnie and Anne just addressed it there, to have a whole government approach to the social determinants of health, that we would, any of our actions or any of our programs or policies would be based on the fact that we have targeted data, that we have an ethnic identifier, that people are trained in how to ask the question, how to put people at ease, that they feel they can give the information and are confident in it. So it'll be based on, I suppose it'll be quality proofed. So we're not just looking for the data for the sake of having the data, that data will be used to channel investment and resources so that those communities that are most marginalised will benefit, their health inequalities will be addressed within any programme of action. Do people, I suppose, I'm just trying to think of the best way to pull that all together. Ronnie, I think you articulated it well a few minutes ago. Would you mind coming back in there, because an area that you've done a lot of work on?
Yeah, but I suppose I think they're all calls to action, but I think for us as community workers, I'm often struck by how few community workers still understand health and the right to health and health inequalities and social determinants. So I think it might be more that we set up a health working group or something like that. Or the other thing I think is useful would be, you know, that as part of that could be that you lobby for the well-being to be put at the heart of government policy in the next government or whatever, because that means a whole of government approach. It means you have to deal with all of these things anyway. So maybe I think that would probably get us further. Do you know what I mean? And that the health working group would be open to obviously other people. Do you know what I mean? We wouldn't be precious about it, but it's around educating ourselves, sharing resources, sharing information, you know, sharing good practice. All of that I think would probably, for me, would probably be a good starting point, you know. And then as part of the work of the group, coming up with a few key asks, you know, so it could be a whole of government approach, it could be the engagement of public health in disadvantaged communities. It could be, as I say, looking at putting health at our well-being, our health and well-being at the heart of government policy, you know. So I think they might be useful.
Okay, any other thoughts or insights from people? I'm not sure if people are familiar with Community Work Ireland. Some of you may well be on working groups that are there already. So I'm presuming, Ronnie, that's what you're talking about, Community Work Ireland Health Working Group or Health Subgroup, Health Working Group, that would, I suppose, inform the work of Community Work Ireland, but also inform us on a broader basis, community workers, in terms of what the asks are of government in relation to health. Yeah, I think.
Yeah, I'd like to just say that I think if you don't have an adequate living conditions, I think that's the very basis of where everything else comes from. So and I mean, the local authority is responsible for local housing, but there's the whole landlords, and you know, it's much wider than just the local authority. But that I think needs to be addressed first, because how can you move anywhere beyond that unless you have that very basic?
It's a social determinant of health, is what it is, but we also know the better educated you are, the healthier you are. You know, we know that if you're born poor or become poor, it's very bad for your health. So these are all social determinants, and they're the kind of issues that I think a health working group could look at. And you could set up subgroups if you got good buy-in, you know, to look at different elements or whatever. But I think that might be, I think it'd be something, but we're not. I don't think we're arguing, Mary Claire. I think we're saying social determinants is at the back of all of this. You can't have health if you don't have, you know, that if you don't deal with the causality, you know.
Yeah, and I think that big issue that, you know, I think Mary Claire's right. The issue obviously of poverty crosses over a lot of groups, and basic income and poverty is the social determinant. And that's again just an interesting figure I've seen in the Wellness report. But again, to say if the lowest 10% income households were to follow healthy eating guidelines, they'd have to spend 74% of their income on food. So I think some of it's about how we make a proportionate response. And that's where I'm thinking, you know, your idea about the group, I think within CWI would be good. And then maybe there should be a group that bring people in from the HSE and other areas, like our two colleagues working in healthy communities. It's like, how do we then ensure that those projects, because there is a focus, I think, on the Sláinte care at the moment, and it's very good in that they're decentralizing care to a local area. They're dealing with chronic disease, they're looking at mental health, older people, and that's all very welcome. But on the other side, there's a lot of focus on health promotion, and I think we have to be careful with that, about saying, you know, what dictates healthy choices. And again, they're saying, are they poor choices, or is it poverty? And is it poverty dictates choice rather than poor choices? So it really is about saying that we have to acknowledge, I think, and Mary Claire is correct, that income thing has a huge impact. But I think that's where that proofing thing would be as well. You have to poverty proof. Your equality proofing would include poverty proofing, social determinant, to do that. And then it would be like, once they do those, I think they're doing community assessments of those areas they're going to work in, to ensure then that they have proportionate responses to the needs of the different groups within the different vulnerable groups within those communities, to make sure our policy responses are appropriate and are. So I think, yeah, I think the idea maybe of a working group would be good, because I do think the New Zealand models look good, some of that stuff. You know, it is about almost informing government and doing a policy or position paper maybe that could be used. As you say, it could be used for lobbying in the next, in terms of local politicians. And I think you're right, Ronnie, you're saying your experience with NEFIT, and I think I remember being part of the National Anti-Poverty Strategy, and definitely that was a subgroup, and it looked across all government departments, and it was chaired by the Taoiseach's office. And that was was probably the most effective committee I worked on, because it brought all the government departments together, and then they had to be answerable to the Taoiseachs. A lot of these cross-departmental committees that we are on, everyone's at the same level, so nobody can make a request of another government department to engage. So it has to be someone. So I think the idea is we have to move up higher, and particularly if we want to begin to address the upstream social determinants, I think that's essential. Yeah.
Thanks, Brigid. So what I'm picking up from this, actually, we've just been given a few more minutes for the workshop, by the way. They've extended it to 2:15, so I was going to be trying to rush you for the last 2 minutes. But so I think we have, if I'm hearing it right, we have our one clear call to action for Community Work Ireland is to set up a health working group or a health subgroup of Community Work Ireland that may grow into something bigger and necessitate subgroups. Is that fair to say that that's our one clear call to action? Yeah, okay.
Yeah.
Okay, well, just in terms of, because the workshop, so we have our one clear call to action. I didn't think that would be that straightforward. It absolutely makes sense, because it gives us all the opportunity, if this is our area of interest, to continue this discussion and dialogue and formulate a series of actions that need to be, and agree a series of actions that need to be taken. But I suppose just because the workshop is being recorded, and we've begun to touch on some of those and communicate some of those actions that need to be taken. So we've talked about a whole of government approach, we've talked about data, the importance of data collection, talked about the importance of equality proofing. I'm going to forget something that somebody has said, talking about addressing the social determinants of health. Are there any other key actions that we would feel we want to kind of name on the table here, because they will be included and looked at as part of the conference report? I'm wondering, is there anybody who hasn't said anything at this stage that really has something they have a burning desire to ensure that it's included, or a point to make?
Yeah, Ciara, sorry, I think Noreen Coughlin's hand was up for question. Sorry.
Hi, no, it was really just agreeing with Ronnie earlier, and again, just from my own direct experience in Ballymun, where we set up a community health forum. I did actually work with Bernardo's Traveller Project for a long time, that's how I know Ronnie. And I saw the wonderful work that the Traveller primary care team can do on the ground, and educating women, and women can really influence their families. But I think Ronnie is absolutely right. I came to this community health concept. When you think of it now, it's such a no-brainer, but it was such a new thing for us. And it was really a colleague in Northern Ireland that brought the concept to us and the way they work. And we brought trainers from Northern Ireland to work with the statutory and the community groups. And, you know, you look back and realize, why was that not so obvious? But there's so many layers in it, and there's so many reasons we need to bring everybody around the table, because we all have different agendas and different understandings. And there's so many, like you're talking about the hierarchy that goes on even within the health sector. If you don't understand that, it's very hard to know how to you know, influence that. And I also think health and wellbeing is a very timely workshop because of COVID, but it also brings in a whole perspective across the community development, across the whole life cycle, across different issue base. So I think it's a really good hook to get people around the table, and also to get under the skin and under the kind of the layers of inequalities and what's really happening. My own experience in early childhood education was that we really had to make the argument, the economic argument, like what you're talking about, that banker, you know, in early childhood, that's been done over, I'm sure you've heard of high scope, and it's going on, whatever, 40, 50 years. And the challenge there is what you were saying is, if the Department of Education spent money, you're saving money for justice, but actually departments work in silos. So they're saying, well, why would we save that department money? We think the government is one unit, but it doesn't behave like that. So it's not just that there's the elections change every 5 years, it's that the civil servants themselves are also behaving in silos. But a big influencer, I suppose, what we learned is, you know, eventually we got a super minister for children. And it wasn't until he became the Minister for Finance did you get the free school year. So Joe O'Brien can be very sympathetic, but unless you have the ears of the person who holds the purse string, that's the person you need to influence. So a lot to do, and I really think you have to start with, it's a slow burner, but we have to educate ourselves. I mean, I'm finding even in Loud, it's just taking a while even for these concepts to be understood and heard. And just when you're talking about the healthy communities, you know, that we don't have one of those in Loud. You know, and you have to, so there's all kinds of inequalities going on. There's all kinds of challenges going on. So the stronger we are together, the easier it is to tackle these. So appreciate that, Ron, for being here.
Thanks, Noreen. That was a very strong point to finish on there. Yeah, stronger. There's a common tagline, stronger together, even better. I can't remember, you'd hear it, it's rolled out quite regularly. If we could live by it, we'd achieve a huge amount. Anyone else who'd like to come in with a comment or a question at this stage? We literally have about 2 minutes left. Everyone's done and dusted. I think what would be interesting, I think if you know, if we are going to come back with this clear call to action to set up a health working group, you know, obviously anyone who's expressed interest in this workshop today, you're working as community workers, or you know, or in community work organizations or funders of community work, you know, I suppose it'd be, I suppose, really important to continue to contribute to the conversation, because often the notion of a working group is a great idea, but then often people disappear again as we talked into their own silos. It clearly, I mean, so much of today has been talking about health inequalities. Dr. Mike Ryan addressed and brought up some, I suppose, really good points, you know, about the need to look at health in a much broader way than it's currently looked at. And I suppose in order for us to affect change, it's important that we would contribute to any working group going forward. There's people here who have different areas and expertise. But I think we all have one kind of common vision. We want to address health inequalities. We want to secure better outcomes for communities. We want health to be looked at in a much broader sense. So I think it'd be really important to consider joining the health working group that we're going back with a clear call to action for it to be established. So if people, you know, if you are interested in joining it, maybe put your name into the chat or a thumbs up into the chat, and we'll capture that, because, you know, when a call goes out for a health working group, you know, you may well miss it, but if you've expressed a direct interest in it, then you know, Community Work Ireland will be aware to, I suppose, specifically come back and contact you about it. I suppose I'd just like to thank Anne and Brigid for their insights and expertise as part of this workshop. Both of you have a long track record in working in health in diverse settings. And obviously a huge amount of that has been specifically working on with the traveller community, as part of the traveller community, for the traveller community, trying to address health inequalities. And a huge, I suppose, a lot of the leading work, you would say, in lots of ways in terms of health has been done by traveller primary healthcare programs. Have set good models of good practice that could be looked at for other communities, and I suppose are, to an extent, as you've broadened out work with the Roma community as well. So thanks a million for your input and your expertise. Thanks everybody else for joining the workshop. We're about to be redirected, so I have our one clear call to action, and thanks everybody for your contributions.
Thanks for your care. Thanks, Ciara.
Bye.